Bonjour et merci pour l'invitation. Je suis désolé, j'avais oublié de préparer mes slides en français et pour cela, ils sont préparés en anglais et pour cela, il faut que je le présente en anglais. So I will turn to English and hope that most of what I say will be understood. If not, we have the opportunity at the end of my presentation to have questions. You can put the questions in French and I can hopefully respond. I'm going to just briefly review some of the things that were already said about me. The reason I'm doing this is because I know from experience that if you're looking at children and adults with autism and related disorders, they actually look the same, whether you're in Japan or Norway or the United States or France or Monaco. They are very similar to each other in so many different ways. However, having said that, it's also important to say that people are all different, and so are people with autism. There's not one individual with autism who is exactly like another individual. In the old days, people used to talk about these things as psychosocial, and they were produced by mothers and fathers not being doing the right thing with their kids. I hope everyone in this room knows that those are days gone by. Autism and related disorders has nothing to do with, for instance, psychoanalysis. It's all to do with the brain and, of course, the environment and, of course, the family and the things we heard from Catherine, but it's definitely not caused by things that the psychoanalysts talk about. I also, since a few years, am connected to the Institut Pasteur in Paris, and that's because together with a group of French researchers there, we were the first to discover a number of genes that actually lead on to or increase the risk of autism. And so I've got a French link as well. Now, I presented this graph many years ago, almost 20 or more than 25 years ago, in London at the Emmanuel Miller Memorial Lecture, showing the overlap at the time of things that were then called Asperger's syndrome or autism with all sorts of other disorders. This graph caused outrage in London. And people like Sir Michael Rutter was really upset, saying, how dare you say that autism overlaps with other things? It's a very specific disorder that sits in its own little box, and it has nothing to do with these other things. But we then did studies in various places across the planet, particularly a big study in Norway, where we looked at the rate of autism symptoms in the general population of children, finding that only 15%, 15% of the whole child population in Bergen, Norway, had no autism suspected symptom. 15% had no autism suspected symptom. 85% had one or more autism suspected symptom. So it's not normal to not have any autism symptoms. This is very important because people still think that autism is, this little box where you can put very severe cases. It's not. It's distributed in the general population in this way. And some people have so many autism symptoms and problems that you actually start thinking, should we call it autism? But the vast majority of people in this room have at least one autism symptom. And that's not because you're related to people with autism or have anything else to do with autism. It's just because all populations have one or more symptom of autism in them. And Lorna Wing the grand old lady of autism, she always said, there's a little tiny bit of autism in each and every one of us. I think this needs to be remembered, particularly in these days when, again, we've come to a very strange point in development where, at least in our country, in Sweden, autism is now over-diagnosed. It's actually diagnosed in 4%, 4%, of the whole Swedish child population, which is much higher than is really even good for autism. I'd just like to say a few words about normal. Normal is way overrated. Who's normal? Do you know a normal person? I don't. I have never met a normal person. It's so strange that we still insist on calling everything normal or abnormal. Normal is everywhere and abnormal is everywhere because we are all a bit different. And some of us have some traits that are perhaps a bit much. Others have other traits that are perhaps a bit much. Some are pedantic. Some are very sort of wishy-washy and will never do what they tell you. Other people are very always worrying, yet other people are always happy. Other people are usually quite sad, etc. But are we normal or abnormal because of that? I think we should get rid of the whole concept of normal. We could have it in our theory, but it doesn't exist. There's nobody who's absolutely middle ground in every which way. So I think also this refers to the horrible concept of typical. Typical people. Who is a typical person? I think most people are people. And I think people with autism are people. I think people without autism are people. And it doesn't make sense to call each other typical or atypical or neurotypical even. However, I think neurodiversity is perhaps an important concept. We're all a bit different one from another. And there is no such thing as one type of brain that's either normal or abnormal. There are very different frameworks when you approach this area. For instance, people have this idea that autism is a disease, or at least a disorder, when in fact it's probably none of that. Autism can be caused by specific diseases, but autism in itself is not a disease. Adhd is not a disease. And I think we need to be careful when we use these concepts. But it is problematic. And it's very difficult if you talk to people from the United States. They talk about autism spectrum disorder. If you talk to people in England, usually they talk about autism. If you talk to people in Sweden, many people will talk about Asperger's syndrome, etc. And so the words are difficult to use, and it becomes more difficult to use as you realize the complexity of the thing that we call autism. So I launched a concept about 10 years ago at a conference in the UK at the Royal College of Psychiatrists yearly meeting in Liverpool that I referred to as Essence or Essence. And essence is just another term for neurodevelopmental or neuropsychiatric problems, but it tries to draw people's attention to the fact that all the so-called neurodevelopmental disorders actually hang together and they don't come in neat packages. So Essence stands for early, symptomatic, syndromes, eliciting, neurodevelopmental, clinical examinations. And all those words are important because early, yes, it's something that starts very early in life. It's usually there either from the beginning or from the first 3 years of life. They are things that produce symptoms in the child, and you can diagnose them according to diagnostic manuals like the DSM or the ICD to neatly fit a syndrome, a syndromal description, a collection of symptoms that constitute a syndrome. And currently, at least in our part of the world, most children with any kind of problem of this type will actually be seen by a specialist. And it varies a lot who that specialist is, depending on where you are. In our country, in Sweden, very often the speech and language therapist is the person who first sees the child with an early symptomatic syndrome. And in other countries, it's the community pediatrician. Yet other countries, it's a child health worker or a psychologist or even a social worker or a child psychiatrist, even though it's quite common for child psychiatrists not to see the very young children, but only to see them at a later age. Now, what are these essence syndromes? Well, the most common is actually not autism, it's ADHD, attention deficit hyperactivity disorder, which affects about 5% of the general population of children. And it's very often combined with something that people refer to as oppositional defiant disorder, which usually means the child is quite aggressive and will hit out at other children, be very sort of troublesome in various almost antisocial-like ways. The next syndrome, if you will, on the list of essence is a specific language impairment. But there are no specific language impairments. So it's a misnomer because people, young children with a language delay and a language disorder almost always has much more than just a language disorder. So it's not specific. It does affect language specifically, but it also affects other areas of development. And it's about 5% or slightly under in most populations, including in Japan, where you might expect that because of the very different system of speaking and reading and writing, you would expect perhaps a different rate. But the rate of speech and language problems in most countries is about 5%. The same holds for developmental coordination disorder or problème de motricité. About 5% of the general population of young children and of adolescents have motor control problems and coordination problems that lead to major functional impairments. This is very underdiagnosed even today in most countries. But motor control problems are actually part and parcel of most of the developmental disorders of childhood. And it's very rarely even mentioned. And this has to change. Intellectual disability is about 2% of the general population, and actually extremely important. If you do meet criteria for intellectual disability, it's much more important than if you meet criteria for autism. Just to mention one reason why it's so important to always look at the whole picture and not just say this is autism. Now, autism, I mentioned, is now diagnosed in 4% of children in some parts of Sweden. We think that's a huge overdiagnosis. And we have published a number of studies from the general population and from the general population of twins showing that autism symptoms are at a very stable rate from 1 year to the next. About 1% of all children in Sweden actually have the symptoms that would meet criteria for a diagnosis of autism. But the number of symptoms that people now tend to base their diagnosis of autism on in our country has gone down. So 15 years ago, any child with a clinically registered diagnosis of autism had at least 8 major symptoms of autism. But 2 years ago, only 4 were required. They still got the diagnosis of autism. No, this is a big problem, and it's a worldwide epidemic. People are making the diagnosis of autism even when the criteria are not met for autism, but they fail to make the diagnosis of the other essence conditions. They don't anymore even diagnose intellectual disability, not speech and language disorder, not ADHD, not developmental coordination disorder. It's all subsumed under the clinical diagnosis of autism. And one of the reasons this has happened is that in so many countries there is legislation in place to protect the rights of people with autism, and you can get some funding for help for people with autism under many laws in many different countries. But you cannot get the same level of funding for things like intellectual disability even, or for language disorder, or for ADHD. Now, there are other things on the essence list, like the tic disorders and selective mutism, and even reactive attachment disorder. For a long time, people believed reactive attachment disorder was all about the way the mother and child had interacted, and the child had been deprived or maltreated. And there's still a lot of maltreatment going on in the group that gets the diagnosis of reactive attachment disorder. But new studies show that the maltreatment is very often the effect of a genetic syndrome in both parents and children. And for instance, if you look at reactive attachment disorder and maltreatment in the context of a twin study that we've done, you'll find that virtually all of the maltreatment is explained by mother, father, and children having the same, say, ADHD disorder with impulse control deficits, etc. And the maltreatment per se is a signal that something is very, severely wrong, but it's not what causes the problem. Instead, children with reactive attachment disorder, not only do they meet criteria for reactive attachment disorder, they meet criteria for all sorts of essence. Many of them have ADHD, many of them have developmental coordination disorder, language disorder, and it's a shame that currently, if a child is maltreated, nobody cares about that child's neurodevelopment. For the future, I hope that when maltreatment occurs in childhood, people should look both at the biological parents and the child and try to help with the problems that they actually suffer from, rather than just saying it's all caused by maltreatment. In brackets at the bottom of this list, you will see a number of things that maybe you think, what's that? What's BIF? Borderline intellectual functioning. It's actually an underlying problem in so many kids with neurodevelopmental problems, and it's never even talked about. We still have a problem with talking about intellectual disability, but we have an even bigger problem talking about children who actually have lower than so-called average IQ. They have a terrible time in schools, they have a terrible time in peer situations, and very often the low IQ contributes to all the other symptoms that they have, including things like depression and anxiety. Among depressed and anxious children, the level of borderline intellectual functioning is much higher than 10% or so in the general population. Then there are all the syndromes that can cause the other syndromes, the behavioral phenotype syndromes. These are rare disorders like Rett syndrome or tuberous sclerosis or neurofibromatosis, usually at the rate of under 1 in 1,000 to under 1 in 10,000 children. But if you take them all together, they're well over 2% of the general population of children. And they usually don't present as, the syndrome. They present with ADHD, autism, intellectual disability, borderline intellectual functioning, and very often they are missed altogether, even in our times, because so many centers that work around children with neurodevelopmental disorders don't include specialists in genetics or medical people who can actually say, these are the things that you need to be looking for. This group also includes fetal alcohol syndrome, which is something that is at a quite high rate, even in our country. More than 1% of newborns will be shown as they grow up to suffer from fetal alcohol syndrome or effects. And we have had a huge campaign in our country to have all mothers stop drinking any kind of alcohol or take any kind of alcohol during pregnancy. And yet the rate of fetal alcohol syndrome has gone up. Most women in our country actually stopped drinking completely. But the few who didn't, they are the ones who were never targeted by the campaigns. And so they've increased in number, the heavy drinkers. And fetal alcohol effects can also present as autism, ADHD, and one of the other essence disorders. Epilepsy is heavily misunderstood from the point of view of neurodevelopment. People consider epilepsy, and for that matter cerebral palsy, to be also these separate boxes where you can put children and say they have epilepsy or they have cerebral palsy. Virtually all children with epilepsy have more than epilepsy. They have all the other disorders on this list as well, and this is usually not even taken into account in clinical practice. People treat the epilepsy, but they don't look at the other things like autism, ADHD, etc. Finally, there's the group with pediatric acute onset neuropsychiatric syndrome, which is a tiny group, but a very important one. It happens occasionally that somebody out of the blue at the age of 12, 13, 14 develop all these syndromes overnight or over a week. Somebody who had maybe a touch of autism or a touch of one of the other syndromes, then suddenly overnight or over a period of 1 week, all these things came together in the most horrible way, usually also with separation anxiety, enuresis, etc. And these are families who are completely misunderstood currently and treated by doctors as, no, it's all make-believe, it's Munchausen by proxy syndrome, etc. So what we know about each and every one of these named syndromes is they predict academic failure. If you make one of these diagnoses, you will know this is a child with a hugely increased risk of academic failure. Sorry, how do I go back? I obviously touched the screen, but swipe. Okay. So they are predictors of academic failure, of other school adjustment problems, social exclusion, substance use, psychiatric disorder, eating disorders, including anorexia, and so-called ARFID, abnormal restricted intake of food disorder, empathy problems. Obesity is also predicted by ADHD, for instance. Antisocial lifestyles and criminality, all the terrible things that you can think of, including a number of physical disorders or so-called physical disorders. And there's even a new Japanese study suggesting that ADHD leads to a higher risk of having high blood pressure in itself, not because of treatment with stimulants. And accidents happen, and road accidents, and increased mortality because of all these things. But if you have several of these things, like most children do, if they have one, they have two. Very many of those who have two have three of the disorders at the same time. you increase this risk more and more. And there's something you can do about virtually all of them. So what would the symptoms, if you will, of essence be? Well, it could be that general development is delayed, or that the motor coordination is delayed, or that the perception or sensory system is affected, that communication and language is much delayed. And if you're looking for just one symptom that will lead to a correct identification of a neurodevelopmental problem, it's actually language delay at 2.5. If you have a child with clear language delay as compared with age peers at 2.5, that child is almost definitely a child with an essence problem, not just language delay, but ADHD, autism, and more language problems with time. It could be that the child is extremely hyperactive or inactive, that the child is not listening, and many children with later diagnosed ADHD and autism have first been referred for suspicion of not hearing, for suspicion of deafness. But then the doctor says, no, hearing is fine, and so the diagnosis of autism or ADHD is delayed for years, just because the child is hearing, so it can't be a hearing problem. But the usual sort of conclusion then is, so it's nothing. But instead one should start thinking, well, any child who is suspected of hearing loss should be thought of from the point of view of, could it be essence? It could be social interaction. When I started out in the field more than 43 years ago, nobody asked about social interaction at the child well baby clinic. But nowadays, parents very often themselves ask, could this be autism? Etc. So social not abnormalities, social interaction problems are very often now the reason why people start worrying. But it could be the stereotypic behavior, it could be mood swings, sleep disorders, and feeding disorders. Having said that, though, sleep and feeding problems are extremely common in the general population. And you should not start worrying until there have been months and months and months of problems and you have not been able to affect them positively. Now, I think these, I'll only show a few more slides, but this one is at least everything that's on this slide is true, which you could argue with some of the other slides I've shown that I'm not so sure. But there is evidence of all that's on this slide. And I think it actually summarizes what we know about autism. First of all, it's not one autism, it's the autisms. And it isn't really a spectrum disorder. I coined the phrase together with Lorna Wing, so I think I can say that it's not a spectrum disorder. If anything, autism is a disorder of several spectra. There's not one spectrum. For instance, children who have the Fragile X syndrome are different from the other children with autism, and children who has fetal alcohol syndrome as a cause of autism, they're different from the others. So there are several different spectra within the autisms. They are multifactorially determined. They always coexist with other developmental or neurological problems in cases with early diagnostic worries. So in our clinic, for instance, we see a lot of children between the age of 2 and 3 with a suspected autism problem. Not one of them has autism only. They all have autism plus, like autism with intellectual disability, or autism with language disorder, or autism with ADHD, or autism with developmental coordination disorder, or autism with epilepsy, or autism with etc. So what you need to start doing in your clinics is, if you see a child meets the criteria for autism, he or she will definitely meet criteria for another disorder that is usually even more treatable than the autism per se. And this is currently not done. People have focused so much on the autism that they've forgotten about the fact that this is a neurodevelopmental generalized disorder or generalized problem that affects many different areas of neurodevelopmental functioning. The people who don't have a comorbid condition and yet look as though they might meet criteria for autism, they don't come to your clinic because they don't need your help. They are not usually impaired. They may be perceived as, little geniuses, little professors, weirdos, whatnot, but they're not perceived as very handicapped. And I've already said that the prevalence of autism is actually not increasing, but the registered diagnosis of autism is hugely increasing over the years. Autism is genetic factors are very, as it were, involved in autism, but there's not one gene. Rather, there are almost 850 genes that have now been shown to increase the risk. If you have a mutation or a variation in that gene, that increases the risk for autism. Many cases are probably caused by a combination of genes from that gene pool, but other factors contribute. For instance, there is now very good evidence that vitamin D deficiency in pregnancy leads to a higher rate of autism in the offspring. Vitamin D deficiency at birth increases the risk hugely that you will have an autism or another neurodevelopmental diagnosis 3 years later. Children with autism have much lower rates of vitamin D than other children, and adults with autism have much lower rates than others of vitamin D. So these other factors are also important. It's not just about genes. One thing that we've shown in a very recent study, which I think is important, is that if you force people with autism to look other people in the eye, that activates their amygdala to the extent that they cannot do and solve a problem properly. And if you listen to adults with autism, they will usually tell you, if I have to look other people in the eye, then I can't hear what they say, I can't think, I get totally confused. And so maybe we should stop forcing young people with autism to look us in the eye, or if we do it, we have to do it very gradually and look at their reaction. I certainly know from a lot of experience with adult people with autism that it helps a lot in doing good things if you stop insisting on eye contact. And yet, over the whole world, people do insist on eye contact with people with autism. I want to say that girls are usually missed when they're very young. If you're a girl and you have autism or another developmental disorder, you have to be very severely affected in order to get a diagnosis. And you would have to look like a boy with that diagnosis in order to get it. Girls who have the same types of basic problems will not get the diagnosis for many, many years, usually not until teenage. And when they do, they will get another diagnosis instead. They will get anorexia nervosa diagnosis, or they will get personality disorder diagnoses, or even psychosis or self-injury or something. But the underlying neurodevelopmental problem is very often, as it were, obscured or hidden by the superficially more social nature of girls as compared with boys. Finally, what can you do in order to help people with essence or autism? Well, first of all, I think the most important thing is to recognize that this is what it looks like. Essence is what it looks like. It's not just autism. So you should diagnose autism when the child fits criteria for autism, but the next thing you have to do if you do that is to think, what else? So that you actually don't miss other treatable conditions. If you look at the outcome, prognosis of children with autism, you'll find autism symptoms in the first few years of life do not predict outcome. You could have 100 symptoms of autism when you're 2, and yet do quite well when you're 30. But if you have low or very low IQ, if you have a language disorder, if you have ADHD, or if you have epilepsy, that will tell you something about the long-term outcome. But currently, people are not looking at autism from this point of view. They're thinking the only important thing is to do the ADI and the ADOS, and hip hooray, now we know it's autism. I am a very great skeptic of the whole industry that surrounds the ADI and ADOS. Experienced clinicians are always better than the ADI and the ADOS. The ADI and the ADOS was created on the basis of validation from experts in the field, and so they can never be better than experienced clinicians. I'm not saying they cannot be used or should not be used, but please don't believe in them like a religious sort of idea that, oh, if we've done the ADOS and the ADI, everything will be fine. Please look out instead for all the other essence problems. I'm sorry to have taken up your time with all this English, but hopefully it's been relatively clear what I've been trying to say. Thank you so much.